Welcome to commonly confused and clinically misused restorative materials. This webinar is intended solely to provide information. It is supported by VOCO, the sponsor, through an honorarium paid to the speaker. Content has been provided by both the sponsor and speaker. The speaker warrants that all figures, photos, and information are his and protected under copyright law. This webinar is not intended to endorse the use of products or services provided by specific vendors. Neither the speaker nor sponsor makes any warranty, express or implied, or assumes any legal liability or responsibility for the accuracy, completeness, or usefulness of any information, apparatus, product, or process disclosed, or represents that its use would not infringe privately owned rights. Duplication and use of the information contained within, without the speaker or sponsor's express written permission, is strictly prohibited. So welcome. Now that we've got the business out of the way, my name is Dr. Sam Simos. I am going to be talking today about commonly confused and clinically misused products. So I'm hoping that you can all take something away from this tonight and use it in your practice. This is a 45-minute presentation, so we're going to be really going fast here, and I hope that you all can, if you have any questions, please give me a call or drop me an email. So today's focus is going to mainly be about understanding adhesives and lights. We're going to talk a little bit about that and why this is so important. We're also going to rethink some filling strategies. We're going to be looking at glass ionomers and bulk fill. It's amazing to me when I travel around the world and talk about these different strategies and products and techniques and technologies, that a lot of people have the same misconceptions and confusion regarding these different subjects. And then we're going to talk about choosing the correct resin cement and steps for placement for zirconia and lithium disilicate. These are very commonly confused procedures, and there's really a right and a wrong way to place these materials. So we're going to explore that tonight. Are you here? And I will tell you a few answers that people come to me with after they listen to my presentation, or why they're coming to my presentation, because they're getting inconsistent results. Maybe they're not, maybe one day they're good, the next day it's not. They want to get more confused about what to use, how to use it, when to use it, why to use it. The names of different materials are confusing. So there's a lot of misinformation and confusion in the marketplace, and it trickles down to our assistants and our front desk and our hygienists. And so we want to get on the same page and kind of allay some of this confusion. The other thing is people want to improve their techniques. I think you can have really wonderful materials, and like I said, there are great materials on the market today. But if you don't know how to use them and in what order to use it in and what clinical situation to use it in, it doesn't matter how great the material is, it's going to fail. So we want to improve those techniques. And the other thing people want to do after they listen to or in coming to a lecture like mine is they want to be more efficient. And I think if you can understand your materials, understand the techniques, understand the technologies, you can't help but be more efficient. And when you're more efficient, your patients are happier, your team's happier, and your profits are definitely more. So with that, let's talk a little bit about the materials and technology that we're going to be discussing today. We're going to be talking about adhesives, curing lights, filling techniques, and selecting the proper resin cements, and then the proper cementation protocol for the different substrates that we use. So when we talk about adhesives, we're going to take you back to your dental school days, and we're going to talk about the smear layer, because really this is where it all begins and ends. And this is what all of the the historical adhesives have had to deal with is the smear layer. Even today's adhesives, we have to deal with it. Well, what is the smear layer? Well, it's all the stuff that's left behind. It's the debris that's left behind from our cutting. And what happens is about 1 to 5 microns deep inside the dentin, and it's referred to as a biologic Band-Aid. It limits the bond strength, and it is porous, and it reduces the fluid flow from the underlying dentin. So we have to deal with this in any adhesive that we use. Well, let's take a closer look at the adhesive mechanism, because what I want you to do when I talk about adhesives, I want you to think about how you use your adhesives, the clinical situation, because we use our adhesives every day. I want you to think about the clinical situation that it's used in, and really how you use it. How do you and your assistant utilize your adhesive, and really what type of adhesive are you using? I want to take a closer look at the adhesive mechanism. Down on the bottom here, we've got our dentin, and we've got the hybrid layer. And what happens is that my slide running here, we've got a bonding agent that penetrates into these vacancies to fill the peritubular dentin areas. And then we've got this hybrid layer that sits on top, and it relies on moisture. Now, of course, on top of the hybrid layer, we've got the adhesive resin cement, and then we put the composite on top of this. So it's a really close look at the adhesive mechanism. But the hybridization relies on moisture, and what else does that hybridization rely on? Well, it relies on light, right? It relies on light. And if this whole process is decreased or diminished in any way, then the rest of what we're doing is decreased and diminished. We're going to have failure. We're going to have short-term restorations instead of longer-term restorations. So what we need to do is we need to look at this and really understand what it is we're doing. And the way that we do it is the way that we place these adhesives and how we work with these adhesives is based on the adhesives that we're using. So let's talk about the different categories of adhesives. And again, I'm going extremely quickly, so if you need to get a hold of me, I'm more than happy to answer more questions. So the categories of adhesives, and I want you to think about the categories of adhesives that you're using. We have a total etch, and the way that these adhesives are described by some people, they either use the generation moniker or they use the parts moniker. So in this case, we've got total etch. That means we have to apply an etchant. And so we can apply a 35 or 37% phosphoric acid etch. And then depending on the type of adhesive, you can either have a 3-part, which has a primer and adhesive, or a 2-part, which just has the etch and the adhesive and the primer in one bottle. So these are the 4th and 5th generation total etch. Next, you have the self-etch. And self-etch is kind of a misnomer. We're going to talk a little bit about that, but self-etch is broken down into 2 parts, 6th generation, 1 part, 7th generation, or 8th generation. And so what happens here is that they've taken the etch and they put it into the bottle itself. So they're saying that you don't have to use an etch, but what they're really saying is you don't have to use an etch for dentin, okay? And what you have to understand with this is that, and I'm just going to say this right now, is that every adhesive has a limitation or a drawback. Of the self-etch is that you have to understand what kind of etchant and what kind of etchant strategy you want to use. I will say that I'm a proponent of not using a self-etch. So self-etch adhesive, I don't rely on the etch itself to etch enamel. It etches dentin very, very well. So I will rely on a selective or total etch strategy when I'm using any of my adhesives. I don't rely on a self-etch, even though the manufacturers will tell you you can rely on a self-etch. I just don't do it because the studies aren't there to prove that. So I'm going to propose a selective or total etch technique, and this is should allay any confusion in the adhesive realm. Again, and I'm not a proponent of using just one adhesive for all situations. I think that in my office, I'm an evaluator for for Dental Advisor, and it's one of the leading testing agencies for dental materials. And so what I like to do is I like to have a lot of materials on hand for different clinical situations, and adhesives are no different. So the other thing is, as I said before, is that there are limitations associated with all adhesives. There's sensitivity with the total etch adhesives, inhibited self and dual cure resin cements in some of these total etch adhesives. Thickness can be a problem. Creation of these matrix metalloproteinases or pore enamel etch can be a limitation. So we want to understand what it is, and I'm not going to get into the minutia of the limitations in this forum, but I want you to all understand that whatever adhesive you're using, there is a limitation associated with it. So I want you to understand it and find it, and know that we have to work around that and find out the clinical situation. As I said, there are a lot of great adhesives on the market. I like Futurabond U. It is a kind of an all-purpose adhesive. I'd like to think of it as a kind of a 9th generation, even though we're dealing with two chemistries here. We've got a chemistry in the bottom and a chemistry on top, and what happens is it's a clever delivery system because you have fresh adhesive in both, fresh chemistry in both of these wells. What happens is you press this and it goes into the primer and adhesive into these different, it's a self-etch, and you pierce this little foil with your applicator, and it's and you go ahead and you put it on. So the question is, well, is it what category of adhesive in it? And I'd like you guys to do this with all of your, whatever adhesive you're using. You want to ask these questions. What category of adhesive is it? Well, I think this is a self-etch 6th generation or 2-part system. And is it compatible with my dual and self-cure resin cements? Yes, it's compatible. And actually it's dark cure. So if I'm putting in a post or if I'm putting on in a buildup, I don't have to worry about whether or not my light gets down into the bottom of that post. I can actually put it on and put it in and initiate the cure, and the adhesive does the rest. Do I need a dual cure additive with this? No, I don't. But see, I'm asking these questions, and I want you to ask these questions about your different adhesives. And then what about in the proper clinical situation? Well, of course, we don't want to use adhesives in a wet environment. We don't want to use adhesives in a bloody environment. We have to control these different clinical situations. And I think if you take these different categories and you look at your adhesive and take these categories and apply it to that and ask these questions, then you'll be in better shape and be able to talk to your assistants and use it properly and stop the confusion. But this is where we start, is at the beginning. The next thing I want to talk about is curing lights. Now you might be thinking, well, gosh, Sam, why are you talking about curing lights when it's a materials kind of a course? And I think that the curing light is probably one of the most overlooked technologies in our office today, because if you think about it, what's dependent? Everything is dependent on our curing lights. Our adhesives are dependent on our curing lights. Our resin cements are dependent on our curing lights. And until we come up with a type of restorative material that's not dependent on light, we have to really understand our lights better. Because, and I get most of my stuff about curing lights through Dr. Richard Price. He's written some of the probably the most articles on dental curing lights. So most of what you see here will be from Dr. Price and his teachings. And the first thing that we have to learn is that all dental curing lights are blue. All of your curing lights are blue. I know it. They're not yellow. They're not red. They're blue. But all dental curing lights are not created equal. And we're going to talk a little bit about that and what you need to know about curing lights so that you can take it back and start looking at this. Because once your curing light and quality techniques and technologies with your curing light, then your dentistry will improve immediately. So let's talk a little bit about that. When poor lights or techniques are used, poor results are obtained. So if we think about it, if we've got undercured adhesives, we're going to get poor result overall. If we undercure our resins, no manufacturer tells us that an undercured resin is acceptable, right? No manufacturer tells us that undercured adhesives are acceptable. So what we have to do is we have to make sure that our lights are curing these adhesives and these resins. And of course, if the adhesive and the resins are not cured, then our bond strengths are pretty much zero and go out the window. Here's a result of undercuring our resins and our adhesives. This first picture on the left, resin. And then of course, we've all seen these types of restorations clinically where they start breaking down in the weakest part of a class 2, which is the interproximal box area, because it's the deepest part and it's the part that our lights are just sometimes not getting to because we're not paying attention. So we have to pay attention to this, and if you've seen this, this is what's going on. If you haven't seen it, then you're just not paying attention, in my opinion. So what do you need to know about your curing lights? Well, you need to know how much power or energy your curing light's emitting. You need to know about the quality of the spectral emission. I know your spectral emission is all between 400 and 500 nanometers, but because it's blue, but what's the quality of that spectral emission? And then we have to understand our irradiance or effectiveness of our light, and we'll talk a little bit about that. And then we're going to talk a little bit about tip size and what you should look for in a light in regard to tip size. So how powerful do we need our light to be? Well, we need enough energy to create a free radical. And what does that free radical do? Well, it creates a chain reaction of carbon molecules that then creates a polymer. And then if there isn't enough power, then the monomers leach out and form a soft spot or low retention. So the power is the key, the initial key to a good light. So how much energy or power is needed? Well, Phillips says that we need 15 joules per centimeter squared. Well, what the heck is that? 15 joules per centimeter squared. I have no idea what that is. What that is 400 megawatt per centimeter squared power output to cure a 2 millimeter thickness of composite over 40 seconds. Okay, so we need at least 400 megawatts per centimeter at 40 seconds. How many people cure their composite or their adhesive for 40 seconds? I would say very few people do that in my audience tonight. So let's talk about what we need then. What's the minimum? This is the minimum amount of light that we need, but let's talk about practicality and what we need to look for. The next thing is blue, spectral emission. We want to talk about the quality of the spectral emission. I know that all of your lights, again, are between 400 and 500 nanometer in the spectral emission. But what's the quality? And if I look at quality, I'm going to look at and draw the example of, you have two cars here on your screen. One on the left is a red car, one on the right is a red car. They both have tires, they both have windshields, they'll both get you from point A to point B. But one is obviously a higher quality than the other. So I'm going to ask you, who would put premium quality gasoline in which car? Okay, what gasoline would you, who would put premium gasoline in the left car? Probably not many people. Probably would put low-grade gasoline in the left car. I would put premium gasoline in the right car. So it's the same with spectral emission. It's all blue. The cars are both red. The spectral emission is all blue, but it's the quality of the spectral emission. So if I look on the left chart here of spectral emission, I see a very flat, spiked chart, and that would be maybe a halogen light, maybe an old halogen light. And as I get farther to the right of this graph, I see a nice clean spike. Now that is a good quality LED light, okay? It's peaking at 456 nanometers. It's got a good spectral emission, good quality spectral emission. So that's what we're looking for. It's the quality. every light is blue, but is it a good quality blue? Okay. And then we're looking for a radiance, and I call a radiance the effectiveness. And what you're looking at here in this picture is what manufacturers call a top hat. And a top hat is simply a mapping of the, and I'm gonna put in this in quotations, the kind of the effectiveness of the heat of the light. We want to see a red and a yellow kind of a spectrum in a good majority of our tip of our light. Okay, and so what we're looking for here is the effectiveness or the irradiance. So I'm gonna give an example of a shower head. And if any of you have ever seen a shower head that sprays a really hard spray of water in a very tiny circular pattern, it's very powerful, effective. And if I'm looking at this shower head of water, it's a little bit better. And even this shower head is even better because it's got a wider range of water to be spread around. But I would tell you that this is the best shower you could ever get, because you can't help but get in this environment, right? So this is a very effective. When we look at effectiveness, I want you to just have this mental picture in your mind, and so this is what we're talking about with irradiance. We're talking about effectiveness, because in all of our lights have these little diodes, okay? And depending on what spectral emission that these diodes are doing, sometimes we'll have these dual output lights, and so they'll have different wavelengths of diodes. Well, what we want to do is have a good irradiance pattern of our diodes, because there's only so much real estate, very small footprint, so it has to count. And so lower quality lights will not have a very good top hat or footprint of effectiveness of the light. It might be very powerful. They might say they're 1,200 or 1,400 megawatts per centimeter squared, but the effectiveness might be very, very, very small. Okay, so when we look at different top hats and different mappings, I would say, of different lights, we can see a huge variation. And this is not to put out different lights. It's just to show the variation in different lights so that you can get an appreciation for the different qualities of lights. And I'm going to go a step further here, and I'm going to overlay these top hat mappings over a MOD bicuspid restoration or preparation. And this is a really nice top hat. This is a nice quality light that has good coverage. You're getting into the MOD, you're getting to all parts of the restoration. How about this top hat? It's still 1,200 megawatts per centimeter squared, but the deepest part of your restoration is not even being addressed here. So I would be very leery of this. Now remember, the light is all blue. You won't know if there's about the effectiveness of this light at all. But when we map it out, it's a very auspicious light. How about this? Even worse, right? Because you've got a very erratic pattern of effectiveness here. This is even worse, right? I'm going to be very leery of curing anything in these areas. So we want to think about this in our lights in terms of, definitely in terms of adhesives, also in terms of resin cements, but how about in terms of just our substrates, how we're using our lights to cure through these substrates for our resin cements, okay? And we'll talk about this in a little bit, but I want you to appreciate that these substrates are very opaque. They're very, very opaque, so the energy that's allowed to go through these lithium disilicates and zirconias is very little. So we want to think about the power that's given out of our tips of our lights, and think about the quality of light that we use. Okay, so I hope I've given you a good appreciation for the fact that you have to look at the tips of your lights and make sure that your assistants are cleaning them properly, because that can affect the power output. I like to test my light every day and make sure that I have different lights in different operatories, and I like to have good quality lights in all of my operatories. But my assistants know that they need to be, the tips need to be cleaned, and that they need to be tested with a radiometer every single day, and then that needs to be logged into a book. So, so we want to make sure that our lights are working, because that is the foundation for the success of our bonding and for the success of our crown and direct and indirect restoration. So I hope I've added a little bit of appreciation for adhesives and for lights. Now, we're going to move on to bulk filling, because bulk filling is a commonly confused and clinically misused material and concept that really, I'm surprised when I talk to audiences around the world. What happens is that they will inherently say the reason that they don't use bulk fill is that for the exact reason that bulk fill was invented, because they don't think that they'll get a proper cure in a deep pocket. So let's talk about the different filling options that you might have. And so when we're talking about a traditional layering technique, that's what a lot of people do, and I'm surprised that many clinicians are still utilizing the traditional layering technique. And I'm not saying that it's a bad thing. I'm just saying that it's very time consuming, and that there are better techniques out there that you can use. And sometimes you have to use a traditional layering technique, right? I mean, you just have to do that. But many times you can employ a different technique to save time and for different advantages that we're going to talk about in a minute. The next strategy is this bulk fill or flowable with a universal cap, and you can do this with a bulk fill that's usually 4 millimeters in, that you can fill it deep, and then you can put a universal composite cap on top of it. Now you can do this with a glass ionomer as well, and we're going to talk about this strategy, bulk fill single viscosity. I'm going to stay away from this tonight because I just don't have enough time, but this is out there, and it's being used in with clinicians today. So let's talk about bulk fill on flowables and why we would use this strategy. Well, what's the number one reason that we would use this material? And it's for adaptation. We want to fill those cabo surface margins inside the preparation, and we want to fill it completely. We don't want to have voids. We want to fill it completely, and that's what a bulk fill material will do for you. It's very it's a little bit runny, and it will flow and stick to the walls of the preparation. So we want adaptation, we want flow, okay? And the other thing that we have with a bulk filling material, I would say the number one reason why clinicians don't use it is because they don't trust the depth of cure. But if you're using a quality light and you have a quality material of bulk fill, you're going to be fine. And you don't overdo the fill, because you have to stay within 3 to 4 millimeters of depth in the deepest part of your film. You're going to be fine, and you can add a couple of different layers, but depth of cure is huge. The other thing that is a big advantage to bulk filling, besides time, is that bulk fill materials are low shrink. So you get this decreased cuspal stress, and so you get decreased sensitivity and decreased cusp fracture, and this is a wonderful advantage over the traditional layering technique, is this low shrinkage. Plus, you can maintain the critical qualities of a posterior composite, and that being compressive strength and wear strength, because you're putting a universal cap on top. So with all of that in mind, let's talk about materials. There are a number of materials. Almost every company has a bulk fill material, but they all are a little bit different. And so I'm going to encourage you to try different materials. I like, my favorites right now are Voco, this extra fill from Voco, and the SDR Plus from Dentsply. But this extra fill from Voco is an excellent material, and you can fill it up to 4 millimeters and then put a capping layer on top. So I encourage you to try that and really try this technique. It will save time. It's a better strategy all the way around. The next type of bulk fill that we're going to talk about is a glass ionomer. And in America, I think glass ionomers are extremely underutilized because they're just difficult to well, Americans have gotten into this bonding type of mentality. And so we've gotten away from the glass ionomers. In Europe, they use it quite a bit, and for good reason, because it's a very, very good material to in the young and in the old and people that have a lot of decay, and just it's a good material all the way around. But it's a little bit it has been a little bit difficult to place, and so let's talk a little bit about this. We can use a couple of different strategies with a bulk fill glass ionomer. We can use a closed sandwich technique where you encapsulate the glass ionomer and use it more as a liner, so that you have at your margin you have a composite that encapsulates the glass ionomer. Glass ionomer releases fluoride and does its thing. The other way to use a glass ionomer in a bulk fill technique is an open sandwich technique, and this is where we expose the glass ionomer to the oral environment, and we lay the composite right on top. Now, the difficulty in this is that glass ionomers are typically sticky. They're hard to place. They're hard to put in the right spot. It's technique sensitive. It's very technique sensitive. So, it's very much easier to put a composite in. So what I want to do is introduce Ionolux, which is a fantastic material. It's a resin modified glass ionomer. It's light cure. So its working time is about 2.5 minutes, but you can cure it, and it's a 20-second cure. It's a huge improvement over traditional glass ionomers because it's composite-like in its aesthetics. And I'm going to show you a case in just a second. But it doesn't require a conditioner or bonding agent or varnish after the placement. It's very low stick, so it's easy to handle. It's high compressive strength, and it's fluoride releasing. So let me show you a case that that I did, and this is the decay. It's an MO class 2. Here's the pre-op, and now we're going to use we've prepared it, and we're just going to place the glass ionomer into the deepest part of the restoration. And because it's a glass ionomer, I don't need any adhesive at this point. I can just put it in, and then I can shape it. Now the glass ionomer's in, so I filled the box. And now what I'm going to do is go ahead and put my adhesive in just like I would a regular filling. At this point, I'm going to prepare it for the composite on top. Now I could have filled it for me. I want to, it's going to be an open sandwich technique. I want that, this was put in a patient that has a high degree of caries, and so I want that glass ionomer to be exposed. And so I'm going to be using Futurabond U here as adhesive, placing my Futurabond U, which is my composite, or my, this is my Admira Fusion from Voco. It's a composite from Voco. And then I'm putting, and then I'm just polishing the restoration with an enhanced cup from Dentsply Sirona. And there's the finished restoration. So it's a very, very easy technique because of the lack of stickiness. It's a very easy handling technique, and a very easy to place. So we've got two strategies for bulk fill. We've got glass ionomer, and we've got the traditional clinical situation. So now what we're going to do is kind of change the mode, and we're going to talk a little bit about our indirects, our cements. Okay, and we want to talk a little bit about this. And understand what it is we're doing when we're using a cement. The purpose of a traditional cement is to fill the micro gap between the crown and the tooth, between the restoration and the tooth, and that's the red line here. So we want to fill that micro gap, but we also want to assist in the retention and resistance of that crown on the tooth. It only assists. It doesn't do it's not meant to be the retention and resistance. That's because of the architecture of the preparation. And then what we want to do is we want to be careful because we have torques and chewing and function, and we want to understand that even the best cements cannot overcome poor tooth preparation with function. So how do we choose a cement? Well, we have to look at the prep architecture. We have to look at the substrate that we're using to put on the tooth, and then we have to look at the microgap. And microgap is one of the things that we overlook quite a bit in choosing whether or not to cement or whether or not to bond. And so there's a big difference there. When we bond a tooth, a restoration to the tooth, we're using mechanical and chemical retention. When we're cementing a crown to the tooth, we're only using mechanical retention. So I think that the best, I'm a bond dentist, so I like to bond as much as I can, okay, given the clinical situation. I think very few of us would argue that the preparation on the left, we would never cement, we would bond, right? Very few of us would argue that point. But yet a lot of us would argue, well, whether or not to cement or bond the crown on the right, or the crown in the middle, or the bridge in the middle. And so the question is, well, why? Why would we deviate from bonding? Is it because of time? Is it because of the clinical situation? What is it? Why is it that we would choose to cement over bond when bond is clearly the stronger of the adhesives? So let's think about that and let's explore this. Well, it could be that we've come from a mentality of porcelain fused to metal and gold, which we had one substrate, which is metal, and we had one luting choice, which is to cement. And so for years and years and years, that's what we've done. We've had that mentality. But something happened not so long ago where zirconia and lithium disilicate became the substrate of choice for most of our practices. And you have to understand that these are far different than metal. They fit differently, they're milled differently, they're made differently. It's a whole different paradigm. So we have to understand that the substrate plays a huge role in our decision to cement or to bond. The next thing that we don't really think about, and that's really very much overlooked, and I think that cementing or bonding a crown is commonly confused, and clinically we're not doing it correctly, is that because of this microgap issue. And what I'm talking about is where the clinical crown meets the margin of the tooth and of the restoration. So what do we do? Do we bond or do we cement? And we're faced with this paradigm of what do we do? And it's clinically, it's clinician specific, I know. There are many clinicians that I know that really never bond a restoration to the tooth, and that's okay. But what I think you need to do is be armed with knowledge. So when we talk about the prep architecture, we have to understand that there are different types of preps. Our preps are becoming a lot more tapered. They're becoming shorter because we're doing a lot more of what I call redo dentistry, which means we're taking off old crowns and we're taking off very, very large fillings. And so our crowns are becoming more tapered and much shorter than they were maybe 10, 15, 20 years ago. So I like to look at this chart because the less tapered a crown is, and the higher or the taller the crown is, conventional cement or adhesive cement, and we can really depend on that. But when we get to be, so that would be retentive, is what I would call the retentive, when it's tall and when it's not tapered very much. And so a material that I would use is a self-adhesive resin cement. And so we can use it on retentive crown. We can use a glass ionomer cement. We can use self-adhesive resin cement. On a retentive crown like this, where the prep is short and the tooth is narrow, but the crown is really resistant to function, we can use a self-adhesive resin cement, or we can use, because it's retentive, we can use a glass ionomer resin cement as well. when the crown or we have to start thinking about a different strategy. And so what we want to think about is when we have a non-retentive crown, meaning we have a lot more rotation before we have any resistance on the crown, we need to start thinking about using an adhesive resin cement, whether it be a self-adhesive resin cement or a dual cured resin cement. We need to think about those kind of strategies in order for the crown to be retained during function. Here's another example where we've kind of got an ice cream cone prep, and in this situation where it's not retentive at all, I would not consider a self-adhesive resin cement. I would consider an adhesive resin cement where I have to put adhesive onto the preparation itself. Okay, so a lot of these situations are presenting, and we have to understand the strategy in picking a cement. And so when we talk about a non-retentive, this is a really non-retentive. We're going to get no resistance to this type of preparation, and so I would not cement this at all. I would bond this tooth in with an adhesive resin cement. Okay. So why bond? Well, another reason to bond is because of the microgap. These microgaps in these lithium disilicate and zirconia crowns are much different than the metal crowns of yesterday. Our metal crowns, we could cast at 20 to 30 microns, and that's what the microgap would be at the junction of the tooth and the restoration. So that's a big deal because the marginal seal resists the microbial leakage when the traditional cements are used. And what's the biggest killer of traditional cements? It's solubility, right? When we have solubility, our cement washes right off. So when we compare that to these CAD milled lithium disilicates and zirconia crowns, we have to understand that these microgaps are huge in comparison to a cast crown. We're looking at 40 to 60 microns depending on the type of mill that's used. So the gap is way too big for the cement to resist microbial leakage. You have to bond the gap with a resin cement to resist the microbial leakage. Okay, solubility is the killer. So this is one of the reasons why I'm such a proponent of bonding with a resin cement rather than cementing with some other type of cement. So, and there are situations when I do cement and I do use so let's talk about a little bit about the bonding protocol. Zirconia and lithium disilicate bonding protocol. Well, what do we do? And people ask all the time, well, how do I bond these crowns in? Well, I was lucky enough to take part in a symposium, one of two clinicians and 5 researchers that took part in a symposium that we decided, we got in a group and decided how to put on these crowns. And these researchers were extremely valuable in this situation. And so we sat down and discussed this on how to put in these zirconia and lithium disilicates. So one of the things that we all agreed on is, well, we've got to remove the temp. And of course you'd say, Sam, well, of course you have to remove the temp. Of course that is. But the problem with removing the temp is that when we're removing the temp, we're not very vigilant about removing all of the temporary material. And that is a bond killer. You have to remove all of the temporary material and all of the temporary cement and be very fastidious about cleaning off that preparation. The other thing is we have to clean the cement from the prep, right? I mean, we have to make sure that tooth is clean. And then we have to control the bleeding. So we want to use aluminum chloride, not ferric sulfate, to control the bleeding, because ferric sulfate will just kill the bond as well. So when we're putting on our crowns and we get a little bit of blood, it's not unusual, but using an aluminum chloride, not ferric sulfate. So we want to control that bleeding, because if we can't control the bleeding, we don't put the crown on. It is not a good idea to put a crown on in a bloody environment. Okay, so and then we want to clean the tooth. And we want to use a chlorhexidine solution to clean the tooth and make sure that we clean everything off, okay? and that's where we want to go. And zirconium. Well, both zirconia and lithium disilicate. But let's just say, what's the difference between zirconia and lithium disilicate? And I'm going to say that the previous slide was the baseline for both zirconia and lithium disilicate. But now what we're going to do is talk about, well, how is zirconia, what do we do after that with just zirconia? Well, how does the lab send zirconia back to you? And usually the lab will send it back sandblasted, okay? It's not etched, it's sandblasted. And when it's sandblasted, after it's sandblasted, you need to try it in and adjust it, okay? So when you're adjusting that, what's happening is you're getting all of the saliva and all these proteins inside the crown and inside the sandblasted area. Well, what you have to do after you try it in and adjust it, and notice I say adjust it before you cement it, because dual cure resin cements really interferes with the bond itself. So try it in, adjust it, adjust the occlusion, and then go on. But then what you have to do is you have to clean the zirconia. And because you have to clean the zirconia because you've tried it in, you've got the saliva and you've got these proteins and you've got these carbohydrates inside all of the surface of the crown. So you have to clean all that out. And I would suggest IvoClean by Ivoclar or bleach. Or you can sandblast it again, and that would clean the crown. Okay, so this is a very important part of the entire process. You have to clean that crown. The other thing you have to do, you should not use on zirconia, you should not use phosphoric acid or alcohol, because you can get the saliva to bind to that if you use phosphoric acid or alcohol. So don't, and it decreases the bond strength and all of this. So don't use phosphoric acid or alcohol on zirconia. Okay, so then after you clean it and dry it, then you prime it, and you should use a primer that's meant for zirconia. Okay, and a number of different companies make a zirconia primer. You just have to look and see. Now that's zirconia. Then lithium disilicate is a whole other animal, right? We have to understand how the lab sends it back. Well, the lab should send it back etched. The lab should send that crown back etched. And we can see that it's etched because it's a little bit frosty underneath in the intaglia of the crown. So we try it in and we adjust it at the time that we try it in. We don't wait to adjust it after we cement it. We try it in and adjust it. And then we have to clean it. Now, cleaning lithium disilicate is a little different than cleaning zirconia. We can use IvoClean, we can use alcohol, or we can use phosphoric acid. This is a very different protocol than the zirconia, right? We can use alcohol and we can use phosphoric acid. So be careful with how you clean your lithium disilicate after you try it in. And then you would prime. Now the question is, can you prime before you try it in? And the answer is yes. You do not have to prime it again after you try it in, but you do have to clean it. Okay, so that's an important part. All right, so why do we need to prime? Priming is a very important part because it strengthens and seals, and it creates a hydrophobic, resin-loving environment, and then you get this secure interface when you prime. So priming is a really important aspect, and it's amazing to me how many people and clinicians really don't understand that you have to prime your substrate before you use your resin cement. The primer's function is that it attaches to the roughened substrate surface, and this is why you have to clean it, because you want to clean all the junk out of this roughened substrate surface. Okay, so it creates a resin-loving hydrophobic surface. Think of a car that's just been waxed and the water beads on that. Resins love that. So lithium disilicates and zirconias look different, but it's the same reason. You prime these surfaces for the same reason. You want that surface to be a resin-loving hydrophobic surface. Okay. The next thing is we want to select a zirconia primer that is specific to zirconia. So if I'm using, now some adhesives can say you can use the adhesive as a primer, and that's because the adhesive has this 10 MDP, phosphate, in it. Okay, and so you want to be careful with that because most experts agree that primers should be used, a specific primer should be used for the restoration itself, not adhesives. Even though adhesives might have this MDP, this 10 MDP, it's suggested that a specific primer should be used. So be careful with that. I think we're getting better, and I think we're getting closer to adhesives being able to be used, certain adhesives being able to be used, but I don't want to suggest that you can use any adhesive. You have to make sure that it has this 10-MDP phosphate in it. And so that's why I just suggest that we use this Z Prime Plus from Bisco, or Kerr has one, a primer. Ivoclar has a good primer, and sometimes you can use it for both zirconia and for lithium disilicate. But either way, I like to use for lithium disilicate, I use a 2-bottle system, an A and a B, because if you use a system that's been sitting on the shelf or sitting in your office for over 6 months and you don't use it all the time, then this can hydrolyze it if it's in one bottle. But if I'm using an A and if it's fresh chemistry in either bottle, and it's got a lot longer shelf life. So that's why I like silane, and I only use it for lithium disilicate. So those are my primers that I use. Now we're going to talk a little bit about resin cements, and we're going to use the rest of this 5 or 6 minutes to talk about the resin cements. So we've talked a little bit about the microgap and about how we need to create this this bond and this resin cement to resist the microbial leakage, the solubility. So the question is, well, do I cement or bond? And of course, when we use a conventional, not as strong as using a dual cure or self-adhesive resin cement, or even a light cure total etch resin cement. So when we talk about relative strengths of these cements, I want you to think about it in a term of, what's stronger, and what do we need to create a nice long-lasting bond. And if you're having trouble with your crowns coming off or your zirconia popping off, and this is a very common problem, and a lot of these problems are happening because we're just not treating the substrate correctly, and we're not using our adhesives correctly, and we're not using our primers correctly. So I want you to go back to basics and kind of think about what you're doing. Now, I'm going to show you a conventional glass ionomer cement. Just as last week I used conventional glass ionomer cement 2 or 3 times when I was putting in a zirconia crown, because the clinical situation dictated it, okay? So I'm going to show you Muron Plus, which is a fantastic glass ionomer resin cement. It doesn't require a primer. It is a very, very strong glass ionomer cement, and it's very hard. So it releases fluoride, and it's got a low film thickness. It's a very, very good cement. And so let me show you how we use this. So this would be for a fully retentive crown, and we're going to use this conventional glass ionomer luting cement. In most cases, if you're using another glass ionomer cement, you need to use a primer. But for Muron Plus QM, you do not need to use a primer. But if you are using a primer, you would use a Z Prime Plus or something like that. Now, we have our retentive crown. We're going to be trying this on, evaluating the bite. Okay, we've got our paper there. Now we're going to clean this out. This is a lithium disilicate crown. We're going to clean this out with alcohol. We're going to put our Muron Plus in, put it over, and it's very, very easy. You just put the crown on and wait 2 minutes, and you can light cure Muron Plus, and then this comes off in kind of a gelatinous state. And so that's the other cool thing about Muron Plus, is that you can light cure this, 10-second light cure, and it comes off so nice and clean. It's very, very simple, very easy. So that's a glass ionomer. It's a great way to go, but I don't use it for everything. I use it for certain situations, certain patients, and so we like to reserve that for that. The next category of cement we're going to talk about is a self-adhesive resin cement. I love this cement. I think self-adhesive resin cement category is probably going to overtake the glass ionomer category because it's just so easy to use. It's stronger. It's a wonderful situation, but you have to use it in the correct clinical situation. You have to use it correctly. So here's a fully retentive crown, and we're going to be using a self-adhesive resin cement. We need a primer on our lithium disilicate. Now, what do we need on the 2 side? Well, because this is a dual cure self-adhesive resin cement, we really just only need to clean the dentin on the 2 side. We don't need any adhesive or anything on the 2 side. So we will prime our zirconia or lithium disilicate. And here's a clinical case, retentive crown. Now I'm showing this for demonstration purposes only. I'm cleaning this preparation with a phosphoric acid. It's a 37% etch phosphoric acid with BAC in it. It's from Bisco. And so I like this because it actually cleans and etches at the same time. I don't need to etch. I just need to clean. So the only reason I'm doing this is that it cleans the dentin, okay? I can also, for demonstration purposes, clean it with a 2% chlorhexidine solution. So either way, whatever you decide, these 2 slides represent either or, okay? I don't want to confuse anybody. But then I use my self-adhesive resin cement. I'm putting the primer in the crown. I'm putting the self-adhesive resin cement, the Bifix SE in, putting it on, light curing it, tacking it for about 5 seconds on the buccal, 5 seconds on the lingual, and then it just peels right off. I mean, this is the easiest stuff to use, and the cleanup is spectacular. Very, very easy. And then interproximally, when you've cleaned the buccal and the lingual, interproximally just put a little explorer through the interproximal and anything in the interproximal back, and I'll final cure. And I'll do a 20-second cure on the buccal, 20-second cure on the lingual. Very, very easy, very, very predictable, and you don't have to worry about anything. This is a very strong cure. So remember this with resin cements, we want to adjust the bite at the try-in. We want to clean the inside of the crown after you try it in. I like to wait 30 seconds after the seat to tack cure because this is a dual cure resin cement, right? Either a self-cure or not a self-cure resin cement or self-adhesive resin cement. But what you want to do is you want to let this chemistry work. And so I'll usually put positive pressure after I seat the crown for about 30 seconds, and it really helps with the chemistry, okay? And then I completely light cure after the cleanup so that I can help initiate light to help shine through the zirconia or lithium disilicate. Enough energy will penetrate that restoration if I use a 20-second cure on the buccal and a 20-second cure on the lingual. So that's really important that we remember this with the resin cements. So the next thing is we're gonna talk about a dual cure total etch resin cement. Now this is different because what happens is that you need to use something on the 2 side. This is a dual cure again, but it's not a self etch, it's a total etch. I need to use something I need to use adhesive on the 2 side. So here's an example of where I would use a dual cure. It's a short, tapered, non-retentive prep, right? I want to use a primer on the zirconia or lithium disilicate side, and I want to use an adhesive on the 2 side. That's the difference here between a self-adhesive resin cement or a dual cure resin cement. So be careful when you buy these things because this Bifix QM is awesome. It comes with everything you need: the adhesive, this resin cement, and the primer. I'm going to show you a video of how I use a dual cure luting cement, and it's pretty straightforward. I'm going to try to narrate it as it goes along, but it's a very strong bond. So if you have a short, tapered, non-retentive prep, this is where I would go all day of the week. All right, so we're going to be doing a bridge prep here, and so I'm taking off the temporary, and I'm going to be putting on the restoration. So we're taking the temporary off. And I'm just slicing that, cutting it off. Good. Yeah. Once I take this off, now I'm going to clean the preparations. And I'm cleaning it with chlorhexidine, a 2% chlorhexidine solution. Then I'm going to try it in. I'm going to check the bite. And if you'll notice, the bite is going to be all centered toward the anterior. So we'll adjust the bite before there's the black mark on the restoration. So it's a little bit high in the canine area. So we're going to adjust that and make sure that the bite is nice and even. Not much adjusting to do. Then I'm going to clean the inside of the restoration with, I use a bleach. Then I'm going to rinse it out really well and dry it. Now it's all clean. And I could have sandblasted this as well. Very easy. Or use IvoClean. But now I'm going to put a primer in. This is Z Prime Plus. Now I'm going to dry that. Good. Now my restoration will be ready to put in the mouth. So what I'm going to do after this, and I'm going to start thinking, well, okay, after I dry this primer in the restoration, I'm going to go back and now I'm going to prepare the tooth. And I like to use the BAC etch from Bisco because it's got the BAC in it. It helps with the matrix metalloproteinases. I'm going to just put it on just to clean it, rinse it off really quickly, and now I'm going to go back and put my adhesive on. Now notice there's no bleeding, there's no water, there's nothing. I'm just cotton roll isolating this. I'm scrubbing in my Futurabond U. And now I'm going to blow it and light cure. Now after I light cure, and I want to blow this really, really well and blow it into the preparation. I didn't show that, but I blow the adhesive into the preparation. And now I'm just going to fill this with the Bifix QM. Seat it. I'm going to have pressure on it and I want to see that material extrude from the restoration. And we're going to just press this down, positive pressure for about 30 seconds. Again, we filled that micro gap. And now we're going to tack cure it and then clean it up. And it's very, very simple and very fast to clean it up. You can see that it comes off in between very easily. We final check the bite. And we're going to final cure it as well. We've got good occlusion everywhere. We check the contra side. And that's it. So now I'm going to open it up for questions if there are any. And I appreciate your time tonight. And if you have any questions, I'm more than happy to answer anything. But have a good night. And good. I'm just waiting for questions. Got a little bit of time left. Okay. So an RMGI, the question is, what is an RMGI? An RMGI is a resin-modified glass ionomer. And so an RMGI is a cement, resin-modified glass ionomer cement, or it can be a filling material as well. Resin-modified glass ionomer can be a filling material for direct restoration as well. So what glass ionomer with fluoride do you recommend? Like I said, I recommend the Ionolux from Voco. I think it's a very good, very easy to use, very user friendly glass ionomer. There's a question, why don't I recommend the phosphoric acid for cleaning zirconia crowns? Because what happens is the phosphoric acid will bind to the zirconia, and it'll trap and bind the saliva to the zirconia. It's not recommended. It also binds the receptor site, so it decreases the all of it decreases the bond strength, actually. So yes, aluminum chloride is what I recommend for any kind of bleeding. I don't recommend ferric sulfate when you're going to bond something. Ferric sulfate is a very good anticoagulant, but it doesn't it does inhibit the bond. The light cure resin cements I will use with my veneers. And there's a number of different ones out there, but I like to use the total etch light cure resin cements for my veneers. I will use for my zirconia and lithium silicate, which is most of the dentistry being done out there today, I like to use the self-adhesive resin cement and the dual cure resin cement. So with that, I'm going to say thank you so much. Here is my information for anybody who needs to get a hold of me and ask any questions. I know I went through this very quickly, but it was time. It was because of time. So if anybody needs any more information, I'm more than happy to give it to them. So thank you very much. Have a good night.